Have you ever been to the hospital and seen a tiny baby surrounded by wires, tubes, or machine and asked or ever wondered, what are all these equipment for? And why does this small baby needs them? Or you are a parent and you are informed that your baby needs to be taken to the NICU, and this brought you fear as well as worries because you don't know what happens at the NICU. You're welcome to another episode of Health Africa, and this is Meet the Practitioners on AAU TV, brought to you by the Association of African Universities in collaboration with the Center for Pregnancy and Childbirth Education, CPACE. On today's episode, we will be discussing the neonatal intensive care unit, which is NICU. We'll try to demystify the experience for parents, as well as explain the various types of care that are provided in the unit, among many others. I know you wouldn't want to miss this, so we'll go for a quick break. When we come back, I'll introduce our guests to you and start the discussion. Please stay tuned. You're welcome back from the break, and this is Meet the Practitioners on AAU TV. If you just joined, you can follow the discussions on our social media handles at Association of African Universities, both on Facebook and YouTube. And my name is Isabella Teta Hinakwa. Today we'll be discussing what happens at the neonatal intensive care unit, which is NICU. And we are pleased to be doing this with our very own Dr. Genevieve Nsiedu, who is the Director of Programs from CPACE. She's been on the set before, and it's been a while since we engaged her. We really miss her, and we're happy to have her here on this episode. Hello, Doc.
Hello, Isabella.
You're welcome back again to Health Africa.
Thank you very much.
We've missed you. Haven't you missed us? No, you haven't. Anyway, we have missed you a lot, and we're happy to have you again.
Thank you.
Great. So first off, can you tell us what the NICU is, what really happens in there? If maybe a parent is being asked to take their newborn there, what at all is that unit for?
Okay, so let's start with the word neonate. When we say neonate, we mean a baby from the time of birth till 28 days of life. So ICU also stands for Intensive Care Unit. So it's specialized care. If you enter an ICU, that means you're going to receive specialized care. So NICU just means an ICU specifically for neonates, newborns between the ages of 0 to 28 days. And it's a very specialized area. A lot of times, mothers are unprepared. I mean, most parents wish that they would deliver and go home. But in some cases, the babies are either born preterm, or they have some congenital abnormalities, or they're having some difficulty breathing. Then they will be sent to the NICU, which sometimes is also called NICU for short.
Okay. Yeah. So these are the conditions that allows the parents to direct their parents to the NICU.
So most times, actually right from birth, if a baby is born and has any difficulty, difficulty breathing, difficulty feeding, or baby is sick, they would bring the baby to the ICU. So sometimes it's not the mother actually walking into the NICU, but the midwives or the doctors delivering the baby will transport the baby to the ICU.
I can imagine how it will be like as a mother just giving birth and you see your baby being taken to the NICU. I can imagine what happens. So
they usually would explain to the mother that there's an emergency with the baby, and so we have to take the baby to the ICU. They may show the baby to the mother briefly, that, okay, your baby, is it a boy or a girl? She identifies it, and then quickly baby is sent. So most of the time in the ICU, you find that the mother is herself on the theater table or she's in the delivery room, and the baby is sent to us. So it's a day or two after that, the mother may come in.
Okay.
Other family members may come earlier. So let's say the father or a grandfather may come, but or grandmother. But the mother herself, it may take a day. It depends on her strength. If she delivered the baby herself, that same day she can also come.
Right. So at the unit, the NICU, we in pictures and on the internet, we see a lot of equipment. So if you can let us know what are these equipment and what are the uses of them.
Okay. So a baby who comes to the ICU has some difficulty. That's why they've been brought there.
Yeah.
We use a lot of equipment to support the babies because let's take the preterm. A preterm is a baby who didn't reach 9 full months before being delivered. And so it's not mature. The heart, the kidneys, the lungs, even the skin is not developed. So we use all these equipment to try and more like simulate what would have happened in the womb for the baby, for the baby to survive.
Okay.
So we have equipment. So the preterms like this, they are cold because they don't have enough fat tissue under their skin to keep warm. So they easily get cold. So we have equipment that warm the baby. So we have incubators, we have radiant warmers. The babies that are bigger or have reached 9 months, but maybe because of maybe a congenital defect, maybe put in a cot. They'll be dressed up, so they don't need the warmers. We have to sometimes give them medications. So you have to put in a tube or a catheter into their veins. You may have to pass a tube to feed them because their feeding tube is a bit, you have to be cautious with it. We have equipment that we use to give them oxygen if they require. So it could be just a simple nasal prong to a ventilator. There are also equipment we use to administer their medications in very small doses, so perfusers. So you come to the NICU and you're bombarded with a host of equipment, but each of them is doing different things for the babies. Yeah.
Right. So, okay, my question is, what you are explaining, it looks a bit scary because a newborn baby going to go through all these, injections, insertions and all that. How does these units look like or feel, and how different is it with other units?
So in the NICU, we have different sets of people there. There's a patient who is a baby lying in a cot or a radiant warmer or an incubator.
Yeah.
There's a staff who vary in different capacities. And then there's also the family or the parents who have to come in. So for us as staff, this is our area of work. So like we are familiar with it. But for the mother or the family that's coming in, when you enter the NICU, you first see that there's a lot of equipment. A lot of alarms going off here and there. People very busy going across. Some are working on a baby. A team is surrounding a baby, actively resuscitating a baby. Some are doing counseling. So different things. It's if you enter the NICU for the first time, it's a bit chaotic. So for new entrants, usually when they come, let's say the mother walks in or the father walks in, first there's a reception to receive and ask the person who you are. They have to identify themselves, and then you now find where their baby is, and then you have to sit with them and counsel them a bit to about their baby and what goes on in the NICU, because it's a very different place from other wards.
In your submissions, you made mention of two conditions that lead the newborns to, which is the prematurity as well as the congenital abnormalities. You've explained of course, it's something which we all know, it's quite common, but the other condition, congenital abnormalities, what it is briefly, and also what other conditions leads newborns to that place.
So when a mother is pregnant, we count the time of pregnancy in weeks. So the date that the mothers are given is usually 40 weeks. So we expect that the mother will carry baby to 40 weeks before she delivers. So some may deliver, if you deliver your baby 37 weeks to 42 weeks, we'll say you're a full-term baby. If you are less than 37 weeks, then we'll say you are a preterm. Now, the preterms is a category of babies who are very immature, so they come with all kinds of problems. Now, the term babies too, you can have either the preterm or the term babies. They may also come with other issues like I mentioned congenital abnormalities. So what I mean by that is when we say something is congenital, it means you are born with it. It's not something you later develop. So let's say you have a defect. There's a defect in how the mouth or the lips form or the way the eye form. So structurally, you can see some things on the body that didn't form well. And then there are also defects that can happen in the internal organs that is also not formed well. So any abnormality on the baby is which baby is born with is called congenital abnormality. So such babies, when they are born, they also come to the NICU. The other categories of babies that they look well, but because of certain risk factors in the mother. So let's say the mother had diabetes in pregnancy. When it happens like that, when the baby is born, there's a risk that the baby may have low sugar levels. And once you have low sugar levels, it's like being very hungry. You can just collapse. So the baby will be there and his sugar levels is going down. Baby can actually may show some symptoms. Sometimes they may not show some symptoms, but the sugar level is important because every part of the body needs sugar. The brain needs sugar. So if it's not going, then that means you are causing some damage to the brain and other vital organs. So such babies too, they may have to come to the NICU for us to monitor their sugar level and be sure that it's okay before they send. Sometimes a mother, before delivery, her water breaks and then it takes like maybe more than 24 hours before the baby actually comes out. Now, once the water breaks, it means the mouth of the womb is also open. So that means infections can track up. So if there's a long delay between the time mother's water breaks and time of delivery, that baby too is at risk of infection. So for that baby too, we may monitor a bit before we let the baby go. So the NICU is also with the various categories of cases or conditions that can come to the NICU, there are levels of the NICU. We have level 1, level 2, level 3, level 4. And that goes with the severity of the condition of the baby and the kind of expertise and equipment that is required to take care of that condition. So level 1 is simply well babies, term babies who are well, but just maybe a few minor issues, they need to be monitored. They'll be in level 1. Level 2 requires some bit of equipment and technical personnel to support the baby. If you go to level 3, then you're thinking of things like ventilation, mechanical ventilation. You have to put a tube in to support the baby's breathing, connect to a machine to support the breathing. You have to get some other specialists, not just the doctors in the NICU, but let's say an ophthalmologist, a cardiologist, other specialties to manage the baby. Then for the 4th level, then that one you are dealing with things like the baby needs complex surgeries. Then that is level 4. In Ghana, there are just a few places that have that level 3. Actually, I don't think we can do a bit of level 4, but nobody really is at level 4. Most of us are actually around level 3. And even the level 3 is just maybe the teaching hospitals that would have that. So majority of the cases are in majority of the newborn setups that are labeled NICU are level 1, level 2. So a lot of referrals then pushes to the teaching hospitals if a baby requires that level of intervention.
Right. We'll go for a quick review and come back. We'll continue with the levels as well as the team that makes up the NICU. Please stay with us. We'll be right back. You're welcome back from the break, and this is Meet the Practitioners on Health Africa, brought to you by the Association of African Universities and the Center for Pregnancy and Childbirth Education, CPES. And in this episode, we were discussing what really happens at the NICU or NICU, and before the break, we got to know what actually it is and the levels of care provided in there, as well as the various equipment we see in there. And we are privileged to be doing this with Dr. Genevieve Nsiedu. Hello, Doc.
Hi.
Thank you for staying with that. Sure. Yeah. So before we went for the break, you made us know the levels of care provided in there. We have level 1 to 4, but you made mention that in Ghana we have up to almost 3, and not even 3, fully 3, level 3. I would want to know, is it lack of equipment, or what is preventing us from getting to the level 4?
Okay, so to have a level 3 NICU, you need to be able to provide ventilatory support, meaning you have to be able to provide mechanical ventilation. And then there are you also need to be able to provide subspecialist care. Now in Ghana, if you take Kolebu, we have a 50-bed capacity NICU, and you have 1 ventilator working. So even though you are providing ventilatory support, it's not commensurate with the number of cases you have. Kumasi also has a setup. It's well equipped, but the number of cases and the equipment you have don't match. Ideally, you should have 1 radiant warmer to a baby, but you have 1 radiant warmer. So when we say a radiant warmer, it's a cot which has a heater on top, so that you can work on the baby, which is different from the incubator where it's enclosed. Now you have a radiant warmer, and it has, instead of 1 baby, you have 3 babies there. They are not triplets. They are different babies. And that is cross-infection because they are coming from different mothers. So in terms of equipment and also even subspecialties. So in Ghana, I think so we have specialists who are well-versed in neonates. They are called neonatologists. We can't count more than 10 in the country.
Wow. And
we have a lot of deliveries. We have a lot of babies. I mean, everybody started, the whole country started as babies. Everybody's a baby before they grow. But we don't have the numbers of specialists that will care for these babies. So then most of these specialists concentrate in teaching hospitals. So if, let's say, you are born in any peripheral hospital and you need the services of a neonatologist, then that means you have to push to the teaching hospitals. And so there's a lot of crowding there. Recently, we had the no-bed syndrome because somebody died and there was a big whatever. But in the neonatal world, it's more than no-bed syndrome. We have no-bed syndrome plus equipment. And because the babies are small, you end up putting them, which is not ideal.
This is a serious situation that needs to be addressed. So you made mention of specialists in the NICU. Who are these people, and what role do they play in there?
Okay, so different people work in the NICU. So you have doctors. The doctors, you have different kinds. So I talked about the neonatologist who is specializing in neonates. We have pediatricians who are specialized in children of all categories. You have medical officers. If it's a teaching facility, then they will have residents and house officers. The nurses, we have different categories. We have neonatal nurses, pediatric nurses, general nurses. We also need, apart from the nurse doctor, we need people like respiratory therapists. So the machines and things we work with, we need somebody to handle them. We need a biomedical engineer who would handle them if there are issues. We need even security. So, the neonatal unit is such that the mothers are not there with us. Recently, we had somebody stealing somebody's baby and whatever. So you have to regulate who comes into the NICU. So you need a security person. You need an administrator. You need a psychologist.
Yeah.
A psychologist, the mothers come in and they are so very stressed, seeing all the equipment, their baby is sick, they can't go home, they have a cesarean section, they have to produce breast milk. They are under a lot of stress, including financial stress, because NICU care is not cheap, it's expensive. So nurses, doctors, you need other specialists like occupational therapists, physiotherapists, pharmacists, dietitians to help with the calculation of feeds. So a host of people you need to run a NICU.
Okay. So what was the duration? First off, I would want to know, you made mention extreme conditions. What is this extreme condition? To the extent that this baby would have to, you made mention of some of the conditions, but we are talking about how extreme it is. Maybe a parent is listening, pregnant, maybe a pregnant woman is listening and would want to know what is termed extreme. And then what are the duration for before a baby, you can say that, okay, the baby is okay and can go home with their mother.
Okay, so duration of stay in NICU varies. It depends on what the baby has. So some can be just a day or two or less than a week in the NICU and they go home. But when we have babies who are extreme preterm, so when I say extreme preterm, those are babies who the pregnancy lasted less than 28 weeks or they are weighing less than 1 kilogram. The rice. The bag is 5 kg. So 1 kg. So less than that. Those are extreme preterms. For such babies, they take a while before they go home. Because aside working through all their medical issues, when they get well, now you have to teach the mother how to handle such a small baby, how to feed the baby, how to do kangaroo mother care to keep the baby warm, how to give medications, all that, and be sure that the mother is comfortable with the care of that baby before you discharge. So some can take a month, 2, 3, 4 months before they are discharged home. So every case and the duration they stay.
Okay, so with the extreme premature, is it the month, let's say 4 months, is it to ensure that they reach the 9 months as supposed to be in the womb, or until, let's say, everything is okay before? I just want to know the calculation.
The target of the discharge is baby is well, can breathe on his own, can feed, and the mother is able to care for that baby. So the target is not to reach the 9 months, but once the baby is well and mother can comfortably take care of baby, baby is growing well, then we go home. So somehow it kind of also goes with the reaching that 9 months, because usually by the time they get to, let's say, 35 weeks, 34, they are very stable that they can go home. But we need to be sure that so somebody can even reach 3 months in the NICU, but if we are not comfortable with the mother's handling of the baby, the baby stays.
Right. You made mention that when you were listing the team or the people needed in the NICU, you made mention of a dietitian. So I was wondering, okay, how do these babies eat? Like, what are they fed with? How do they survive there?
Okay, so breast milk is our go-to in the NICU because it contains a lot of things that the formula milk does not. So we have, back to the preterms again, because they make a majority of the cases, even the term babies. The breast milk contains antibodies that help fight infection, which is not found in the formula. It also contains certain enzymes and hormones that help the baby to grow well. So in the NICU, we are trying to make this baby survive. So these things in the breast milk help us for the babies to become better. How we feed them. So if a baby is less than 32 weeks at the time they are born, they usually are unable to swallow. So then if you put food in their mouth, it will just be there or it can go down the wrong way. So we usually will pass a tube either through the mouth or through the nostrils straight into the stomach and feed through the tube.
Okay.
So for that, the mother would express the breast milk, and then the nurse would push it down the tube. Depending on the condition, sometimes we may feed small volumes and gradually build up the feeds. Sometimes even the small feeds, some of the babies are unable to tolerate, so we may connect the tube to a machine we call a perfuser, so that it gives the food drop into the stomach over like hours, like 2 or 3 hours. So instead of just pushing the food one time, we go slowly. We call that gavage feeding. So these are ways we use to get the baby to be well. Then after that, when the baby is well enough and can breastfeed directly, if he's unable to breastfeed, mother will still continue to express the breast milk, and then we'll feed by cup and spoon.
Okay. And you made mention of ventilation, breathing support. Now you were saying sometimes as part of the ways to feed them, you pass through the nostril. I want to understand, what are the breathing supports available in case maybe this feeding is passing through this, the nose, the nostril? How then? Let us understand. Yeah.
Okay. So babies breathe through their nose. They don't have the sense that if something is blocking my nose, I can open my mouth and get air through there. So as much as possible, if we have to support a baby with breathing, we prefer that we pass the tube for the feeding through the mouth into the stomach, so that we have the nostril available to attach our nasal prongs. Sometimes the babies are working very hard at breathing. You can see their chest going in and out. For that, just putting on oxygen by nasal prongs is not enough. So we use something called CPAP, continuous positive airway pressure, so I can force the air down and open up the lungs of the baby. If that one is also not working, then we'll now go to ventilation with the mechanical ventilator. So for that one, we don't go through the mouth. We actually will put the tube down the throat into the airway pipe that will take it straight into the lungs, and then connect the tube to a machine, the ventilator. Yeah. So those are ways we support the breathing of the baby.
Okay. And so before we wrap up, it's important we hit on this again, especially Ghana not having the enough equipment needed for us to get to level 4. And I know CPACE, these are some of the reasons why you are existing. Let people know, and also bring together funders, investors, or people who want to support. So this is the good platform. I would want you to reach out to policymakers, investors, or the industry out there for their support, because you are in the field and you know how these children are suffering. So I would want you to reach out to them. What should they hear? Something to convince them to, support babies get the equipment needed.
Okay, so I'll start by saying that if you take babies from day 0 of life to 1 year, and look at the number of babies in that group that die. Currently, our statistics says that we have about 28 out of 1,000 children between the age of 0 and 1 year dying every year. Now, of that group, 0 to 1 year, 60% of them are dying in the first 1 month of life. So if we're able to do something about neonatal care, it will change the number of babies that are dying, so that they can survive into and do what they are supposed to do in the future. And I don't think it's the work of just government or policymakers, or it's everybody. Everybody, in the sense that if you're pregnant, you should seek antenatal care, because certain interventions they put in there for you at antenatal care affects the outcome, the baby that you are having. If the mother has infection, it can affect her baby, but if it's treated, then the baby is well and avoids coming into the NICU in the first place or needing NICU services. So that's one. Then 2, everybody lives in a community. Walk into a hospital and ask, is there something that I can do? Is there something the community can do? People do luxurious birthday parties, big funerals, big posters. All of that is money, but we can do simple things that can affect a baby's life. Mothers are stressed a lot in the NICU because of just finances. Our fathers should support us. The baby doesn't come from just the mother alone. It's from the family. It's two that make a baby. So they should support the mothers so that the mothers are comfortable, less stressed about the finances, and also get the emotional support to help with the baby. For government and foreign partners and investors, neonatal care is big, and there's a lot to be done to make sure that our babies survive. From providing equipment to ensuring that every facility where a baby is born at least have some level of neonatal care, whether it's level 1, level 2, because the immediate things you do for a baby affect his outcome. Even if he's transferred later to a higher facility, the immediate things count. Lastly, I would say that for our mothers, and then even for the staff that work in the NICU, we should recognize that the mothers are going through a lot of stress. Currently, we're doing a little study in our unit, and we realize that even for a mother to enter the NICU is a scary event for some of the mothers. So some of the mothers don't show up, not because they don't want to see their baby, they are just scared. Yes. So as staff also working in the NICU, we need to recognize that and reach out to the mothers so that we help them, we support them, whether emotionally, get a psychologist for them, address their fears, address their questions so that they're a bit more calm to take care of their babies.
All right. Thank you very much. Thank you, Dr. Nsiede. Thank you so much for doing this with us and letting us know how important the NICU is and also the importance of antenatal care. And we would want to see you again. We have a lot to discuss, so please don't run away from us. We'll reach out to you again and have you here to talk on other health issues that addresses neonates, issues. So thank you once again for coming.
Thanks for inviting me.
Okay. And this brings us to the end of today's discussion on neonatal intensive care unit, NICU or NICU. As heard, you've heard how extreme or how disturbing and worrying it is when you are informed your baby is taken to this unit. So to our mothers, let's ensure to, go for antenatal care. And these are some of the steps that will prevent you from going there. And to our fathers, it takes two to bring a baby. So support them. We all need the support, not just the father, the community, the mothers. In fact, everybody needs to come together and provide for this baby. My name is Isabella Teta Hinakwa, and we are hoping to see you again on our next episode. Have a good day.